Yes, very well.
Yes,
Okay,
we
just
can
want to
hear
make
you,
sure
Meryl.
I can be heard.
Perfect.
Okay, wonderful.
Go
So
ahead.
I'm going to be talking to you about echocardiography of pulmonary venous anomalies. And I'm just going to briefly touch upon some developmental considerations. When you think about how the pulmonary veins develop, the lungs and the trachea, tracheal tree formed from the foregut, the pulmonary vascular bed originally comes from the splanchnic plexus, and eventually the splanchnic veins establish a connection with the common pulmonary vein, which is incorporated into the left atrium. And the site of the development of the common pulmonary vein remains controversial, but this is basically the concept of how the normal pulmonary venous bed develops. So when you think about pulmonary venous anomalies, they fall into a number of categories, the most common being abnormal connection. You can have partial abnormal pulmonary venous connection when at least one of the pulmonary veins does not connect to the left atrium, or total anomalous pulmonary venous connection, where all of the pulmonary veins make a pathway to someplace other than the left atrium. You can also have abnormal drainage, and these are usually congruent, meaning usually when you have abnormal connection, you have abnormal drainage, but there are some exceptions to this rule. And then you can have disease within the pulmonary veins itself, either pulmonary vein stenosis or atresia or pulmonary veno-occlusive disease. These are diseases that carry very poor prognosis. And then you can have abnormal common pulmonary vein absorption, which leads to cor triatriatum. Some people call this divided left atrium. And here are the examples of a situation where you don't have congruence between abnormal drainage and abnormal connection. Here you see on the left side of your screen, abnormal drainage with normal connection, which you can see in association with a deviated or displaced septum primum, as you see here. So the right pulmonary veins are in the normal location, but they are draining to the right atrium. And then you have the scenario, which is not terribly uncommon, of hypoplastic left heart syndrome, where you have mitral atresia and intact atrial septum. The pulmonary veins are connected normally, but they try to find a means to get out because there's severe obstruction to flow. And so the left atrium develops these pathways, levoatrial cardinal veins, which make their way back to the systemic venous circulation. And then finally, you can have abnormal connection with normal drainage. We see this in the setting of patients who have pulmonary veins that come to a confluence and connect to a left superior vena cava behind, which then drains directly to the left atrium. Or sometimes you can see what looks like a confluence behind the left atrium, which is draining directly to the left atrium. So that's abnormal connection with normal drainage. And then partial anomalous pulmonary venous connection comes in a variety of subtypes. The most common being left upper pulmonary vein to innominate vein, but you can also have partial anomalous pulmonary veins that go directly to the coronary sinus, typically the left veins. And then there is a constellation of findings called scimitar syndrome, where one or more of the right pulmonary veins, typically the right lower pulmonary vein, connects directly to the inferior vena cava. And then you can have right pulmonary veins to the superior vena cava, either in isolation or in association with a sinus venosus defect. And then you can see ipsilateral pulmonary veins, where the right pulmonary veins drain to the right-sided atrium, the left pulmonary veins to the left-sided atrium, which is seen typically in left isomerism or the polysplenia form of heterotaxy. So some of the talking points or sort of tips I give to sonographers and echocardiographers and trainees when considering looking for partial anomalous pulmonary venous return or connection: always suspect that you have partial anomalous pulmonary venous connection when the right ventricle is dilated, but you don't see an atrial communication. And in sinus venosus defects, you almost always have partial anomalous pulmonary venous return and or connection, and that's generally the rule. And if you see one pulmonary vein draining anomalously, there may be others too, so you should look for them. And a very important imaging point is that you should look at the limits of the mediastinum for vertical veins, and be particularly vigilant in patients who have Turner syndrome, who have a fairly high rate of partial anomalous pulmonary venous connection. And that can be missed in the setting of, for example, repairing the coarctation of the aorta. And then if you see a newborn baby who you're evaluating for pulmonary hypertension and they have mesocardia or dextrocardia, you should always think about scimitar syndrome and try to identify if there's a pulmonary vein connected to the inferior vena cava. So this is exactly the setting I was talking about earlier, which is that you have a patient who we followed after coarctation repair in Turner syndrome. It was reported multiple times that the patient had some dilation of the right ventricle, but it was never sort of determined what the cause of that right ventricular dilation was. And then when somebody looked really carefully in the suprasternal frontal view, you can see the vertical vein here from the left upper pulmonary vein, which is draining anomalously. And so it was picked up quite late in this particular patient. Here you see in the subcostal sagittal view, a very nice demonstration in color compare mode of a sinus venosus of the SVC type defect with the right upper and right middle pulmonary veins connected directly to the right superior vena cava. You see that in this transesophageal picture on the right side of your screen, where the right upper pulmonary vein is connected directly to the superior vena cava. And we can use even three-dimensional imaging to help us with this diagnosis. If the right pulmonary veins are draining high on the superior vena cava, then the patient may require a Worden procedure, where the right pulmonary veins are baffled directly to the left atrium, as you see here. And the superior vena cava is divided and a portion at the portion above the right pulmonary veins and connected directly to the right atrial appendage. And so the superior vena cava sits more anterior than it would in the normal heart and is particularly at risk for obstruction after that procedure. Here you see some SVC Doppler acceleration after a patient has undergone a Worden procedure. And nowadays, in somewhat older patients, there are innovative treatments for this type of defect where you can use covered stents to get the superior vena cava blood directly into the right atrium and the pulmonary venous blood over to the left atrium. We talked about scimitar syndrome for a bit, but here are two pretty nice examples. The first picture on the left side of your screen shows you that in a sweep of the heart, you notice mesocardia. The apex is sort of pointing midline rather than to the left, and that should raise your suspicion that there might be scimitar syndrome. You can see in the subcostal sagittal view that the right lower pulmonary vein is coming into the inferior vena cava just at the level of the diaphragm. In addition to the partial anomalous pulmonary venous connection that you see in scimitar, you can also see a constellation of other findings, including right lung hypoplasia. That's what causes the mesocardia or dextrocardia. You can have an aorta pulmonary collateral to the right lung, as well as pulmonary sequestration in the right lung. Moving on to total anomalous pulmonary venous connection, there are a variety of ways this can happen as well. About 45% of patients will have supracardiac total veins, meaning that there is a vertical vein connecting to somewhere above the heart. You can have the cardiac form in about a quarter of patients, usually direct to the coronary sinus, but occasionally directly to the right atrium. And then the infracardiac form, almost 20%, where the vertical vein connects somewhere below the diaphragm. And the dreaded mixed type, where some pulmonary veins drain to one place and some drain to another place. And then the lethal form of total anomalous pulmonary venous connection, where you have no vertical vein or vertical vein atresia. And I will show you an example of that. Some helpful hints with regard to echocardiography in total anomalous pulmonary venous connection. Look at the atrial communication. If you do not have all right to left shunting at the atrial level, you do not have total anomalous pulmonary venous connection, because it is obligatory right to left shunting, because that is the only way that blood is getting to the left side of the heart. And of course, that communication must be adequate in size, because it's going to be determining all of the cardiac output out of the left ventricle. It's important to try to identify all 4 pulmonary veins when you're looking at the confluence in total anomalous pulmonary venous connection, because if you have mixed total veins, the prognosis is much worse, and I'll go over that a little bit later in the talk. The confluence is typically visualized behind the left atrium, and so in apical 4-chamber view and in other imaging views, you'll see that the left atrium appears bald. This is important, especially when you're imaging immediately in the postnatal period in a patient who is extremely cyanotic, and you're trying to determine if the patient has total veins or actually has persistent pulmonary hypertension of the newborn. And it can be hard to make that determination quite quickly, and these are some tips to help. And then once you identify that the patient has total veins, then you should follow that pathway, determine a mean gradient by Doppler, and then I'm going to present some information to you about another Doppler means of making determination of obstruction called the pulmonary venous variability index. And then the vertical vein pathway. In supracardiac, you typically have a horizontal confluence. The pulmonary veins come in horizontally, and they connect either to the innominate vein, to the right superior vena cava, or if the patient has a left superior vena cava, they can connect there too. And then infracardiac veins have typically a vertical confluence. The pulmonary veins sort of come in what we call an upside down Christmas tree formation, and they connect to either the ductus venosus, the portal system, or the gastric vein. They do not connect directly to the inferior vena cava. And this form of total anomalous pulmonary venous connection is commonly obstructed for a number of reasons. The ductus venosus is a fetal structure which closes soon after birth, and so that can cause constriction at that level. There can be constriction as the vertical vein passes through the diaphragm. There can be obstruction just by nature of the length of the vertical vein and the fact that it has to sort of make a 180-degree turn to get the flow back to the systemic venous side. And then you have total anomalous pulmonary venous connection to the coronary sinus, where the coronary sinus is markedly dilated and has this whale's tail appearance, which I will show you. So before you even know where the pulmonary veins are going, a couple of important features of total anomalous pulmonary venous connection. You have to have obligatory right to left atrial shunting. So if you see that, then you have to start looking to determine if you have a total anomalous pulmonary venous connection. And here you see in that apical 4-chamber view, the baldness of the left atrium. The left atrium looks small here because the pulmonary veins are not connecting to it. And so you don't have that sort of Mickey Mouse ears appearance to the 4-chamber view. And often, particularly when there's obstruction of the veins, you'll see that the right ventricle is quite dilated, and there will be flattening or even bowing of the ventricular septum because of the high pressure that reflects back to the pulmonary vascular bed. So here is an example of supracardiac total veins. When you do the subcostal sweep, this is an LAO sweep, you can see the septum primum, it was deviated all the way over because of the right to left atrial shunting. And you can just make out the pulmonary venous confluence just behind the left atrium. Again, the left atrium looks bald. You see the deviated septum primum in the apical 4-chamber view. And when you look at the suprasternal frontal view, you see the pulmonary venous confluence, which is horizontal in nature. And then all the veins are sort of being pulled in a direction towards this vertical vein, which is making its way up the left side of the mediastinum, crossing the LPA, and then going into the innominate vein there. Superior vena cava flow will also be increased because of this increased flow. So you'll see that you'll see that the right superior vena cava is often dilated. And here's just a still frame showing you that confluence directly behind the left atrium. It's important to determine the difference between the confluence and the pulmonary arteries in this situation. And here are some other variations of supracardiac veins. Here is an example of the confluence making its way to a vertical vein, which connects to a left superior vena cava. And here on the right side of your screen, you can see the confluence here crossing over to the right and making its way over to the right superior vena cava. Infracardiac total anomalous pulmonary venous connection, you should, if you're suspicious, start imaging in the liver to start looking for those connections. Here you see the difference between the aorta and the vertical vein. Let that come around again. So here's the aorta, here's the vertical vein making its way down into the liver, and then eventually connecting to a hepatic vein to the ductus venosus. And here you see the ductus venosus flow is accelerated here in that connection. And you can see how tortuous this flow pattern is, how it has to make its way all the way down, cross over, and then make its way over to the ductus venosus. And so it makes this quite vulnerable to obstruction. And if you do the suprasternal imaging, suprasternal frontal imaging in this group of patients, you'll see that sort of upside down Christmas tree, if you will, as the pulmonary veins connect to the vertical vein, which is making its way down below the diaphragm. So here you see the veins sitting way below the pulmonary arteries with the vertical vein going in the direction towards the diaphragm. And then this is an example of cardiac total veins where you have total anomalous pulmonary venous connection to the coronary sinus. And it has that whale's tail appearance. You see sort of the pulmonary veins making their way into the large coronary sinus, and the os of the coronary sinus is markedly dilated. You see the obligatory right to left atrial shunt here of the foramen ovale. Again, you see the hugely dilated coronary sinus in the apical four-chamber view, and you can see the color flow pathway making its way, the veins making their way to the right side. The right ventricle here is, of course, dilated. And then obstructed total anomalous pulmonary venous connection can occur in any of the subsets we talked about. You'll often see an RV that's dilated and not working well, depending on where the veins are coming from. Typically, if this is in the newborn period and you have a ductus arteriosus, the ductus arteriosus will be all right to left, and that indicates that the pulmonary vascular resistance is very high. And then you can make a determination of the pathway and where the obstruction is occurring. So in this example of a vertical vein that's making its way over to the superior vena cava, you can see that there's probably a vice-like obstruction as the vein passes between the RPA and the bronchus there. You can also have obstructed veins, as I said, below the diaphragm. As you can see here, you can see the acceleration of flow as the vein, it's making its way into the liver. And you can Doppler this area and get a mean gradient, in this case, a mean gradient of 12 millimeters of mercury indicating obstruction. Of course, these patients will also have cyanosis, so you're not only relying on the echo to make the determination of obstruction. And then the dreaded mixed total anomalous pulmonary venous connection. It's important to make this diagnosis in part because the surgeon needs to know if their anastomosis is including all of the pulmonary veins or not. Here's an example of 3 of the pulmonary veins making their way to the coronary sinus, and then the obligatory right to left atrial flow. And you can see I've labeled here right upper pulmonary vein, right lower pulmonary vein, left lower pulmonary vein, all to the coronary sinus. And then the left upper pulmonary vein is making its way to the innominate vein, as you see in this moving suprasternal frontal picture. Now, why is this of major concern? Well, we've done some work in our own institution looking at this cohort of patients with mixed total anomalous pulmonary venous connection. And you can see from our cohort of 6 patients who had this, 5 of them had to have reintervention. And of the 5 who had reintervention, it happened relatively early. Several of them had significant ectopic atrial tachycardia in association with the reobstruction, and 2 of them did not survive. So in the cohort of patients with total anomalous pulmonary venous connection, who generally do pretty well if they don't have single ventricle physiology, then this is a cohort that is at higher risk than normal. Briefly, just to touch upon heterotaxy or isomerism. In left isomerism, the most common anomaly is ipsilateral pulmonary veins, where the right pulmonary veins enter the right-sided atrium and the left pulmonary veins enter the left-sided atrium. You have theoretically 2 left atria in this situation, and that is perhaps why this occurs. Whereas in right isomerism, where you have quote unquote two right atria, the pulmonary vein venous confluence may not be able to make its way to the heart because there is no left atrium, and total anomalous pulmonary venous connection is common. They may be obstructed in this situation, and they're often associated with other complex heart disease, such as double outlet right ventricle or right ventricular aorta with pulmonary atresia, single ventricle. And so in that context, the risk is extremely high. Here is an off-axis parasternal view showing the ipsilateral pulmonary veins. The atrial septum is right here, dividing the right-sided veins from the left-sided veins. And here is one of my favorite echo clips of all, showing infracardiac total anomalous pulmonary venous connection to a vertical vein here. There's also pulmonary atresia in this patient and 2 RPAs. You'll see in the sweep that there's an upper segment vessel that comes off in mirror image. They have bilateral SVCs. And so you could really just put a line down this echocardiogram and show, and there's hepatic veins on either side of the atrium too. So you can really see the mirror image notion of this right isomerism in this particular patient who has total veins below the diaphragm. We looked at our risk factors for postoperative obstruction in total anomalous pulmonary venous connection. We had almost 120 patients, of which a significant number, 40%, had single ventricle, and over a fifth of them developed postoperative obstruction. And the risk factors for postoperative obstruction included single ventricle, if they needed an additional procedure at the time of their total veins repair, if they had the mixed type, which you see here in purple, which has the worst survival of all, and if they had preoperative obstruction. And then how do we detect preoperative obstruction? Well, we can do it by way of this venous flow variation. This was other work done by my colleague Brian White here at CHOP. We looked at almost 140 patients, of which a significant number had heterotaxy and single ventricle. And we determined that this pulmonary venous variability index, which is the maximum velocity minus the minimum velocity divided by the mean, was fairly sensitive to predict obstruction in this cohort of patients with a very good interclass correlation coefficient. So you could really, and you can see that it's this PVVI is really able to differentiate patients who have significant obstruction from non-significant obstruction. I told you about this example of vertical vein atresia. These are typically patients who are born immediately severely cyanotic, and often this is not known, and they're transferred to a tertiary care facility with the notion that they may have severe primary pulmonary hypertension, but in fact they have this lethal anomaly, which is total anomalous pulmonary venous connection with vertical vein atresia. You can see in this sweep that there is a tiny little confluence there. You can see all right to left flow across the ductus here. And often in severe pulmonary hypertension, you'll see retrograde flow in the transverse arch as the blood is trying to get to the brain. You can see that this patient is on an oscillator to try to ventilate, but this is a lethal anomaly because even if you try to put this patient on ECMO or try to fix the veins themselves are very, very small. The lungs have been significantly damaged by this, and it's unsurvivable. And there's the entire pulmonary venous confluence behind the heart. It's like a little string. And then occasionally patients will present late to you with total anomalous pulmonary venous connection. And so here is a patient who presented to us at 10 months of age. You can see that the coronary sinus is hugely dilated in this patient. The RV is massively dilated. It looks like this patient has severe left ventricular hypoplasia, but in fact, the left ventricle is relatively normal in size, but you can see how compressed the left atrium is between the coronary sinus and the aorta there, and essentially there's very little filling of the left ventricle that occurs in this situation. So eventually their systemic output is compromised. But to show you how much remodeling can occur, this is that same patient. So this is the initial parasternal short axis view where you see a markedly dilated right ventricle compressing the left ventricle, but 6 months later, you can see a nice rounded ventricular septum with normal filling of the left ventricle. And here you see severe tricuspid regurgitation because of the RV dilation and pulling away the leaflets, but the valve itself was relatively normal. So after repair, you can see that the tricuspid regurgitation became trivial. Chordtria triatum is an incomplete regression of the common pulmonary vein, which you see in these two examples. The left atrium is divided by this membrane. It's often funnel-like with an opening just above the mitral valve. The pulmonary veins come into this posterior chamber, and the left atrial appendage and foramen and the mitral valve are in the outside chamber. This obviously may be obstructed, as you can see in this example, and that's at the mouth of the common pulmonary vein. One other thing to point out in this population is that it is associated with partial anomalous pulmonary venous connection, and so you should look for partial veins in this situation. And then you can have the subset of patients who have pulmonary vein stenosis or atresia. If you have the congenital form of this, you can have abnormal proliferation of fibroblastic cells, and this can be seen in premature infants as well. There's also an association with common AV canal or common AV septal defect, and this carries a very dismal prognosis. If you have acquired pulmonary vein disease after pulmonary vein repair, it can be seen at the surgical anastomosis of the confluence or within the veins themselves, particularly if they were small to begin with. And risk factors for pulmonary vein stenosis include heterotaxia or isomerism. You can see it in hypoplastic left heart syndrome, in scimitar after repair, mixed total anomalous pulmonary venous connection. And in adults, we have seen some cases of pulmonary vein stenosis after ablation near the pulmonary veins for atrial fibrillation or flutter. The repair that is performed is attaching the confluence directly to the left atrium. If you have obstructed total anomalous pulmonary venous connection, this is a surgical emergency. There is nothing we can do medically to help those patients. You have to either put them on ECMO support if you can't get them to the operating room right away, or take them to the operating room urgently. This is the type of operation that sometimes has to be done in the middle of the night. With unobstructed total anomalous pulmonary venous connection, it can be repaired electively, either when the diagnosis is made or in the first few weeks of life. The confluence is then anastomosed to the left atrium. The vertical vein is typically ligated. And if you have total anomalous pulmonary venous connection to the coronary sinus is unroofed, and then the os of the coronary sinus is closed to the left atrium. And mixed total anomalous pulmonary venous connection may require a number of strategies. Here is an example where of total veins to the coronary sinus where the unroofing was inadequate. So you can see that the os has been closed, but there is significant narrowing from the residual roof of the coronary sinus in the left atrium. So this patient had significant obstruction and had to go back to the operating room to have further unroofing of the coronary sinus. So in conclusion, know the variations of pulmonary vein disease and the potential connections when you're imaging a child who you suspect has pulmonary venous disease. Most can be diagnosed by echo only, but we consider cross-sectional imaging when we can't see all the pulmonary veins well by echocardiography. If we suspect mixed total anomalous pulmonary venous connection because the prognosis is different for that subset of patients, and because the surgeon needs to know what strategy they might need to perform. And when you have concern for pulmonary vein stenosis itself. And it's important to recognize the risk factors for postoperative obstruction to know to look for them once the patient has been repaired. Thank you very much for your time. And I will stop sharing.
Thank you. Supposed to say anything now, Grace, or do you want to make some comments?
Yes, please.
Well, listen, Meryl, of course, that was textbook, classic Meryl Cohen presentation. Very great. I'm happy to have been some influence to you early on in your life, and I've also been interested in total veins. And by the way, you know, total veins was really a bust as an echo diagnosis until the inclusion of Doppler color flow. Doppler color flow has changed how we can diagnose this condition. And I think there's only one important thing that I need to say about that, is that you have to lower the Nyquist limit, because venous flow is usually under 20 centimeters per second. So really, if you want to do this, and anytime you look at veins or coronary arteries, if you don't lower the Nyquist limit, you may miss the velocity of flow within those vessels. So that would be a plea for me to ask everybody that's maybe early on in their careers to do, is that when you evaluate total veins, that you lower the Nyquist limit, lower the scale. Usually under 40 will get it for you. You may have to even make it less than that.
Yeah, I appreciate that comment, and I didn't put that in the slides, and I appreciate that you added that. Thank you.
Yeah, I mean, I know. And so the other issue here is, I see the very nice echo machine that you've got. Yes. And of course, that echo machine has been designed to increase the frame rate so that you can do strain rate imaging, because you can't do good strain rate imaging unless you have a frame rate of over 100 per second. And when the frame rate goes up, the Nyquist limit also goes up. So the tendency is for modern machines to default to the highest Nyquist or scale setting. So you have to consciously be prepared to lower the Nyquist limit. And if you don't, you're going to get bitten.
Yeah.
What else did I have? Oh, the one thing I wanted to say that you had mentioned, but to enforce this, is that the left atrium is made up of two components. It's made up of a component of the primary heart tube, and then it's made up from a component of the pulmonary venous bud, which presumably now has been confirmed to arise just on the left side of the atrial septum. Mm-hmm. And, you know, the thing about total veins is that the left atrium is almost always small or smaller than normal. So not only do you have to look for the bald left atrium, but you see the aorta is displaced posteriorly because of the massive tissue there. So that's very important issue. And, you know, Meryl, you showed very beautifully also that the ventricular size changes dramatically when you do the repair. And in fact, in the operating room, as the patient is connected to the circulation, their own circulation, discontinued bypass, the volume and the loading on the ventricles changes dramatically, so that the right ventricle becomes smaller and the left ventricle becomes larger. And it's almost, the picture you showed is almost immediate in the operating room. So
it's you know, we always worry about left ventricular hypoplasia in the setting of total anomalous pulmonary venous connection, but the left ventricle is almost always adequate in this situation.
Well, I wrote a paper about that once, and we made the estimation of this, and we found that if you just could take the convexity or the concavity of the ventricular septum in this condition and just add it up, you get almost a normal left ventricular pressure. So it's a loading condition and a physiology rather than an anatomical deformity.
Right.
And so I think that's important not only for this, but for other forms of congenital heart disease. Now, the other issue, just a little caveat, is that the supreme intercostal vein drains into the innominate vein. And when you're looking up there, you must make quite sure you're not looking at the supreme intercostal vein and do Doppler in there to make sure that you're looking at a vertical vein. The only other issue
that can be difficult to distinguish, I would say.
Well, yes, but the Doppler flow in a systemic vein is different to a pulmonary venous flow. So I think that's where you have the option, and it's usually a small vessel. Mm-hmm. And one of the surgical strategies is to disregard the anomalous venous connection because it's so hard to get to, and maybe take it at a later time when the vein is bigger. So I think that's the only other thing that I wanted to add. Now, let me just give you, and you should answer that. The first question comes from Credine Hifiani, who asked, which is the best echo view to identify the pulmonary veins? And I'm going to let you answer that.
Well, I use a number of views, but, you know, obviously there's the classic crab view that we use in the suprasternal view. But honestly, what I find is people go to color right away in these views. You really should try to identify the pulmonary veins by 2D imaging first. I start in the subcostal view because that's the view I start in, and I start to look for the veins in that view immediately. In fact, the right upper pulmonary vein, which is often hard to see in the crab view, I will often identify in the subcostal sagittal view. Many people start that view at the SVC and IVC, but actually if you go just to the right in that view, you can see the right upper pulmonary vein coming into the left atrium. And I think if you identify that early, then you don't have to worry that that's anomalous. Yeah. But I use all my views. I use the apical view, I use the parasternal views, and then of course the crab view, to try to identify it. And, when you have total veins, as you said, Norman, the left atrium will look funny to you. It will look small. It won't have that look to it that it gets from when the pulmonary veins are entering it. So that should raise your suspicion.
Yeah. So I think that in summary to Hifiani, we should say that what you do when you do an echocardiographic evaluation is that you examine the whole heart. Yeah. And you have to put these things together in one way or another. I mean, I would say that the four-chamber or the subcostal four-chamber view, looking back at the veins, is probably the easiest way to see it, but it's not always the case. And you have to try and discover, in fact, from this, like the suprasternal notch, when you see a vertical vein draining to the innominate vein, you have to actually see that. The other point that I think we need to make for the people that are tuned into the seminar is that basically there are only two kinds of pulmonary veins, those that are obstructed and those that aren't. And when it's not obstructed, they like an ASD, and they have the same physiology as the ASD. The others, the ones that we want to identify, even from in utero or from early or after birth in the critical period, is to get those veins, because you made that point very clearly, that this is the last of the pediatric cardiology emergency procedure. There's nothing you can do to make these patients better other than a surgical procedure. Okay. So it's very important. And Marshall Jacobs, your colleague, wrote a paper when he was still active about the transfer of fetal patients at birth directly into the operating room without passing go. And echo is such a strong technique for making this diagnosis. And I think that the longer you wait and the more contrast you put in and the larger the pulmonary vein is only to the patient's detriment. So I think good echo is the actual winning point for these patients, because the longer you wait and the more you pump them with the toxic and volume loading ionic agents, the poorer the result will be.
Yeah, I would make the point that this is still a diagnosis that often is not made in utero. It's a bit challenging to make this diagnosis in utero because there's obviously less pulmonary venous flow in the fetus. And so even if you're doing a four-chamber view, and even if you're doing outflow views as a fetal screening, you may miss that the patient has total veins, and the patient may not have a fetal echo either. So these patients will present, if they're obstructed, in the newborn period, and will often be transferred to a NICU with the notion that they have primary pulmonary hypertension because they're blue. They're on very high pressure settings on ventilators to try to get their PVR down, which they'll never get down if they have total veins, no matter what they do. And so it is sort of the emergency and the quick determination of an echocardiographer to say whether the patient has total veins or not. I mean, they can present in a similar way. One thing I would say is that even when you have primary pulmonary hypertension, it's unusual. I wouldn't say it's impossible, but it's unusual to have all right to left atrial flow. There's often bidirectional flow, but in total anomalous pulmonary venous return, it's obligatory. So it's a really nice, like if you see right to left atrial flow as you're doing your first sweep, you should always suspect that there are total veins and then start looking for where they might be and looking for the confluence in that situation. I can't hear you, Norman. You're muted.
Sorry.
That's
So
okay.
there's an interesting question from Sufala Adi, and he said he saw a 24-year-old supracardiac TAPVD. How would you manage this? Please give me an answer, Meryl.
It's highly unusual to see that, I would say. I mean, I would catheterize that patient to see what the pulmonary vascular resistance is, to see if it's operable or not. If the pulmonary vascular resistance was okay, I think I would still operate on a patient like that.
Oh, I think that's absolutely correct. I mean, I think that this is still a surgical condition when you find it in a 60-year-old.
Yeah.
I mean, we've repaired ASDs in 60-year-old patients, and the physiology of total veins without obstruction and an ASD are really quite similar. And so is the presentation with the big right ventricle and paradoxical septal motion, et cetera. But I think that once you've made that diagnosis, this is a surgical condition until you get to the extremes of life where I am now occupying it. So I think that's there's one question here. I don't quite understand it, from Abdali Al-Shaheli. Great talk. Well, I agree with that. Have you seen total anomalous pulmonary venous connection drain to atresia of the Thebesian valve of the coronary sinus?
Oh my goodness. I have not. Have you, Norman?
No, I haven't seen that either. I mean, it maybe drains to the coronary sinus. I mean,
are they saying coronary sinus, so draining to the coronary sinus with coronary sinus osteoatresia maybe is what they're indicating?
Well, I think if he's talking about that, we've seen that, of course.
Yeah. Yeah. I mean, the example I showed who has total veins with vertical vein atresia, I assume you've seen that, Norman. I've probably seen it, I think, 4 times in my career. It's, of course, a patient who is, deathly ill. And there have been a couple we've put on ECMO and then tried to connect the veins to the left atrium. The confluence in those situations are very sclerotic. And so no matter what you do, there's sort of nothing, that can help. Yes. And the pulmonary and the way those patients are living for a few hours is that they have connections between their pulmonary veins and the bronchial veins, which allow the blood to get out, but obviously in a very inefficient way with a lot of suffering as a result. And but I have not seen coronary osteoatresia or connection to a Thebesian vein.
I've seen coronary osteoatresia
with total veins.
No, not with.
Yeah, right. I've seen it without total veins. Yes.
Right. Well, this is very interesting. I just want to make one other little plea, and that's the use of saline contrast echocardiography. Mm-hmm. I mean, it'll tell you either whether if you've got total veins, and the patient's alive, there's obligatory right to left atrial shunting. Right. So a little bubblegram will tell you if immediately you see a huge amount of opacification on the left heart, that you've either got severe pulmonary hypertension or total veins. Right. And in fact, many times the microbubbles are trapped in the pulmonary circulation. And so the venous structures on the distal side of the pulmonary veins highlight themselves in silhouette as black structures. I think our color Doppler has made it less useful to do, but certainly that's a very valuable technique for defining veins. And that's all I had to say about that. The issue of right isomerism, Meryl, is very interesting because the pulmonary veins when you get that in right isomerism, puts up this in the RAC score in a region beyond the 5 grades. It becomes a RAC 6 grade because it's such a complex and dangerous surgery, and the results are terribly poor. Many years ago, 20 years ago now, the group from Toronto looked at their experience with right isomerism, and in those patients requiring surgery on their pulmonary veins, none of them were alive after 5 years. So we can still expect a poor prognosis with these patients.
Right, and what I would say about that, in addition to what you just said, is that when you have pulmonary atresia or severe pulmonary stenosis and total anomalous pulmonary venous connection, you have basically an inflow to the lung and outflow to the lung problem that makes the pulmonary vascular bed likely very abnormal. So even if you put a shunt in and try to repair the veins in those patients, they ultimately wind up often with pulmonary venous stenosis later on in the veins themselves. And those patients, and then, often those patients have single ventricle as well, and the prognosis is extremely poor. When we looked at prenatal diagnosis of heterotaxy syndrome, we found that those patients, we did not improve outcome with prenatal diagnosis. And it's not because we couldn't be accurate in our diagnosis, it's because the disease is so bad, it doesn't matter if you make a prenatal diagnosis, the outcome is poor because of the, because of the substrate.
Absolutely true.
Right.
So here is another interesting question. What are the signs of TAPVD on the chest X-ray?
Yeah, I didn't show a chest X-ray. I should have done that.
Meryl, I'm going to let you try and answer this one.
Well, if it's a late diagnosis, you will. So first of all, if it's an early diagnosis of obstructed total veins, you will likely see white out of the lungs because you have such severe pulmonary venous congestion that you basically won't be able to tell the difference between the lungs and the heart in the X-ray. It'll be the so-called whiteout. If you have a late diagnosis of total anomalous pulmonary venous connection, particularly unobstructed and supracardiac, that you get this so-called snowman appearance of the X-ray, which is because your vertical vein, innominate vein and SVC are so large, they form a silhouette above the cardiac silhouette, so that you sort of see these two structures on top of each other that has that appearance.
Yeah, well, I think that's correct. And also, if you get a late diagnosis, you're going to get enlargement of the pulmonary arteries.
Right.
So you'll see these big balls of pulmonary arteries, particularly centrally. And in fact, total pulmonary venous obstruction or atrial left to right shunts in general, they don't produce pulmonary vascular disease, pulmonary hypertension. They produce a pulmonary vascular and thromboembolic disease. And then the thrombi embolize off the large pulmonary arteries and continue to erode the size of the pulmonary vascular bed. So generally, they can be operated on, but as you had mentioned, when you get a late patient, I think the expedient thing is to consider all the data and consider cardiac catheterization for measuring the pulmonary vascular resistance and seeing what the other issues are related to this.
One other X-ray finding just to mention is the scimitar and scimitar, particularly in a newborn with scimitar, if they're presenting with pulmonary hypertension, you'll see the shift of the heart over. You may see the sort of so-called scimitar on the X-ray, but you may not. But certainly if you see that the right lung looks hypoplastic in a newborn, you should always look very carefully to make sure they don't have scimitar.
So Meryl, there's some other wonderful questions over here. Some of them I really don't know the answer to this. So I'm going to let you answer this.
We don't either if you don't. I know.
So the question is there a place for CT or MRI in the diagnosis of total anomalous pulmonary venous return?
So the answer there's always room for those types of imaging. And I would say that if you feel confident in your diagnosis by echocardiography, then you don't require those types of imaging. However, if you can't see all the pulmonary veins, if you're very worried about where the vertical vein pathway is, if you're worried about pulmonary vein stenosis or the size of the pulmonary veins, and being able to prognosticate to the family what the likelihood of survival is for the repair, then I think that that type of cross-sectional imaging can be helpful. And as I said, if you're suspicious of mixed total veins, because the prognosis is worse in that population, you may want to confirm that before going into the operating room, so the family is aware of the potential risks.
And let's not just minimize surgeons and surgical observation. Helen Taussig had a sign called the Taussig sign in total anomalous pulmonary venous return, which he developed in the autopsy room, because the thing that holds the heart in the mediastinum is the pulmonary veins. And if you don't have pulmonary veins holding the heart in, you can flip the heart over very easily. So that was called the Taussig sign.
Oh, I didn't know that. That's a really interesting, it's absolutely true. When you do, if you take the specimen on block, right, that has total veins, you can very easily move the heart up and down.
Right. So we're standing on the shoulders of giants, aren't we?
That's for sure.
Okay. So she did that. Then there was, so the question about these, again, the two syndromes. There's the syndromes where there's obstruction in total anomalous pulmonary venous return, and then there are the ones without. The ones without, there's no problem with investigating them either with MRI or CT scan. CT is much quicker. It does a great job, but it's got radiation. So everything is, a consideration of what's best for the patient. But if you take a patient with total veins, with obstruction, and you take them to the CT scanner, for example, you're going to create even more problems, because you're going to give them the volume load of the contrast. We don't do CT without. So the thing is not to avoid these things, but to be expedient about doing what test is necessary.
Right. And I think the patient can actually die in the scanner when you're doing that.
They can die in the scanner. They can die even before they get to the operating table.
Yeah.
So I think that we need to enforce that point with this group here, because we should have. What about the small LV? Do you ever get excited about it in the presence of total veins?
Almost never. We get very excited about it in arch hypoplasia, obviously. It's like sort of a different type of filling abnormality. But I think for the most part, when you have total anomalous pulmonary venous connection, the LV is usually recoverable, as you have shown in your own work. I have not seen many clinical scenarios. I'm not sure I've seen any clinical scenarios where the left ventricle has been deemed inadequate after repair.
And what would you say about CT in the post-surgical?
Yeah, I think that CT has a role there when you're worried about pulmonary vein stenosis. There's lots of new strategies for treating pulmonary vein stenosis that we used to not have in the cath lab. So stenting, dilation, etc. And I think CT in that situation is a very useful tool to help you know the degree of the stenosis, the length of the stenosis, where it's occurring. Echocardiography is not particularly good at detecting that. It can detect whether you have it or not, because you'll see acceleration of the Doppler jet coming into the left atrium, but knowing exactly where the location is or the length of the stenosis is not something we're particularly good at by echo imaging, and it makes sense. So those are situations, it's a great question, where cross-sectional imaging is very useful and is needed.
So here's a lovely question. You'll have to put on your Bob Anderson hat for this.
Uh-oh.
The question is there a difference between venous drainage and venous connection?
Yes. Yeah, well, I mentioned that, right? So venous, I mentioned that in the beginning of the talk, right? So connection means that it is connected to someplace other than the left atrium, right? So the veins themselves are not connected to the left atrium, but drainage means that they are not draining to the left atrium. And you can have scenarios where you're connected normally, but draining abnormally. such as the patients with HLHS with intact atrial septum who have pulmonary veins that are coming into the left atrium, but they have nowhere to go. They can't go across the atrial septum, they can't go across the mitral valve. So the patient forms a connection, a vein that makes its way to the systemic venous circulation, whatever you want to call that vein. So that is an example of abnormal drainage with normal connection.
Okay, thank you. So that's taking care of the difference between the. There's a question by Brijoy Vishanathan, who said, how to differentiate LSVC to coronary sinus and TAPVC, or just the LSVC to coronary sinus connection?
How do you make the distinction? Is that the question?
Yes, that's the question.
You have to follow where those structures are. So if you have total veins to the coronary sinus, you know, that whale's tail image I showed you, that was obviously an ideal image. That's one of the best pictures we have of that, but you actually see the connection of the pulmonary veins into the coronary sinus. When you have an LSVC to coronary sinus, so that's like sort of a, you know, perpendicular to the coronary sinus connection. Sure. When you have an LSVC to coronary sinus, it's sort of more parallel, right? You see the LSVC sort of just making its way into the coronary sinus. Often in LSVCs, you don't have a bridging vein, so you can confirm it with that. And you can use contrast also to help you with that.
I was just going to ask you about that.
Yeah.
Of course, it doesn't obfuscate the patient who's got an LSV coronary sinus and veins draining into the LSVC.
Right.
You know, but I mean, that's a rare issue. So
it is rare, but you can use contrast in that situation, injection in the left arm, and make that.
Right. I always do left arm injections. Yeah. So anyway, there's another here, Paulo Zielinski, our friend from Rio Grande do Sul in Porto Alegre, Brazil, has asked you to comment about the point that I made about the increased separation between the descending aorta and the left atrium in total anomalous pulmonary venous return. I think we've actually answered that for Paulo,
yeah.
But I think he wanted us to emphasize that point. So we've just emphasized it. And then Amana Alamin has a clinical problem with a patient, a 4-month-old with total anomalous pulmonary venous return, who underwent a repair. We don't know which way the veins were draining, but the path after surgery still preferred to go from the pulmonary vein confluence through the vertical vein. And so I'll have to let you answer that question.
So some surgeons don't ligate the vertical vein. I don't know if you've had that experience, Norman, but there are some surgeons who decide to leave it.
Sure.
And this is one of the potential consequences of leaving the vertical vein open. Oh. So what I would say is if you've made a connection, but you still have preferential flow that's going through the vertical vein, it's very likely that your connection is obstructed.
Correct. That's I think the point.
Yeah.
You know, because a number of surgeons have not gone in to sneer the vein. And so I think that's it.
Yeah, I mean, the blood will find a way. And so if it can't find its way back into the heart because the confluence connection is narrowed, it will preferentially flow through the vertical vein. And so in that situation, you might want to cath that patient to identify if there was confluence narrowing, and then potentially coil the vertical vein if need be. I remember once, you know, I say always try to find all 4 pulmonary veins, and I remember making a diagnosis of total anomalous pulmonary venous connection to the coronary sinus, and the patient went to the operating room and seemed to go okay, and then came back a few months later, and there was obstruction, like that example I showed you, incomplete unroofing of the coronary sinus. And what happened was I had missed that there was a left upper pulmonary vein to innominate vein. And because of the obstruction at the repair, a lot of the blood was preferentially flowing back to that left upper pulmonary vein to innominate vein, which was tiny in the newborn period, but became very large because of the obstruction.
Sure. Yes, I think that we should just look. This is a fabulous session. I can't tell you how much I'm enjoying your replies. But I want to read you this because we never get this. This is not really a question. It's from Evan Ahmad, who said, "I love the conversation between my two role models, Professor Norman and Professor Meryl. Thanks to the Congenital Heart Academy." So let's leave it not as the answer, the final answer, but let me get back to the other issue about anomalous veins. So if you've got mixed veins, the surgeons may elect on the basis of the illness of the patient and the state of the pulmonary vascularity to do the major repair and leave the pulmonary vein. Now, one of the problems with anomalous pulmonary venous return of just one vein is that there is a difference between the pulmonary arterial pressure and the pulmonary venous pressure, and the pulmonary arterial pressure and the systemic venous pressure. So that because it's lower, there's a tendency for more and more blood to go through the vertical vein. So the vertical vein can become enlarged. Now, that's not necessarily such a bad thing, because the biggest problem in fixing these little vessels is you're dealing with very, very tiny vessels, right, and it's very difficult to do. So perhaps leaving them is a better object if you're going to repair them later. Of course, right, just as you explained in your patient, if you leave this for any length of time, you're going to get a huge amount of blood flow going through the anomalous vessel. So that's a problem through life that perhaps our older pediatric cardiology monitors and the adult congenital people might want to take care of.
So I'd say I'd make 2 points here, Norman. One is, you could ask, why are mixed total anomalous pulmonary venous connection patients at higher risk for not doing well? And there might be a number of reasons, but one of them is, when you have a confluence that has all of the pulmonary veins coming into it, I would imagine that the pulmonary veins are a little bit larger in that situation. Mm-hmm. Whereas if you only have a couple coming into the confluence, the veins themselves might be smaller, and mm-hmm, smaller veins may beget obstruction later. So I think that's part of the reason why mixed veins don't do as well. The second point I would make is that I think how the surgeon repairs them and the sort of trajectory of the connection of the vein to the left atrium can have an impact. For example, in scimitar syndrome, the partial anomalous pulmonary vein is sort of, it's in parallel to the heart. It's not coming towards the heart like a normal pulmonary vein comes to. It's going down into the inferior vena cava. And so to get that vein that's going down to cross over to where the left atrium is can be extremely challenging. And so those patients are at very high risk of that vein becoming obstructed. And so if you don't have to repair those in the newborn period, you really shouldn't, because the vein is small, as you said, and also is sort of going in the wrong direction. And so you can put a baffle in there, but that can become obstructed. And so those are very challenging situations with regard to how you repair the vein. If you're repairing infradiaphragmatic pulmonary veins, I mentioned that the confluence is often vertical. And so the way the surgeon attaches that to the left atrium is in a vertical orientation rather than horizontal. And you can also see how that, if the veins are near there, they might be kinked or something like that. Pulmonary veins are very sensitive to being touched. That's why surgeons, when they're doing reoperations, will do what's called a sutureless pulmonary vein repair. It's, because you really don't want to touch them if you don't have to. So there's a lot of challenges in these types of repairs.
Sure. Well, I mean, there's a comment here by Wafa Yusuf who said, a very interesting presentation. Thank you. And I think that's true. I just want to make a couple of more points that I think are important. And, obstruction occurs, as you explained, with infradiaphragmatic, no problem. But as you mentioned, and my figures are a little different, I thought 60% in my series of veins drain vertically. And the veins, if you look at the back of your hand and you look at the venous anatomy on the back of your hands, you'll see that your right hand and your left hand have variable venous patterns of drainage. And so venous drainage is a variable issue. Now, when of the total veins with obstruction, the commonest are not infradiaphragmatic because they form only a small percentage. The ones that are the most common are supradiaphragmatic. And in that situation, we have what they call the hemodynamic vice, because the vein lies between the trachea posteriorly or the bronchus posteriorly and the right pulmonary artery anteriorly. And so that's where the obstruction occurs. If the vein runs in front of the pulmonary artery, there's no obstruction.
That's right.
And that's a fascinating condition because, I mean, for older clinicians that have been with these patients have been sent in to the nursery as pulmonary hypertension. And they make a certain maneuver and the patient gets better. Then the next neonatologist comes in the next day, and the patient gets worse and he makes it again. So they have an undulating course. And the course is undulating because as the patient develops pulmonary hypertension, the pulmonary artery gets large and squeezes on the vertical vein between the trachea. Well, what happens is after a while, the cardiac output decreases. When the cardiac output decreases, the pulmonary hypertension diminishes and the flow goes out. So the patients have an undulating course. And this is what, as an echocardiographer, as a cardiologist, you have to be aware of when they tell you that there's a patient with with pulmonary hypertension in the nursery that they're looking at, that total veins with obstruction is a common cause of this presentation, and we have to make sure that we're not dealing with total veins in this situation.
Right. Anyway, I think we've run out of time. Probably we've been over an hour now.
Over time, but I mean, you know, the thing that's important is I think questions are wonderfully interesting because you get to understand what the audience wants to understand. And of course, the audience is variable in their skills. And so it's great to get these examples and to be able to directly give feedback to these patients about their problems.
Absolutely.
So
and anybody can contact me who has any additional questions. Please feel free to email me. You know, I love this audience. It's a great audience, always very engaged.
Sure. I can just say that in the Congenital Heart Academy, I have discussed the echomorphological correlations of this condition. I have beautiful examples of pathology of all the various kinds of total and partial anomalous pulmonary venous return and the issues and complications that you can get in. So I say, thank you, Meryl. It was wonderful to see you.
Thank you, Norman. It was always wonderful to chat with you, always.
Yeah, we thank you. And we thank Dr. Agati, Sasha Agati, who runs the Congenital Heart Academy, for having things work absolutely flawlessly this morning. And goodbye to you all.
Bye, everyone.
Bye.